Neonatal Care Part 3. We're going to begin discussing specific conditions that the newborn or the neonate may experience. In this lecture, we're going to talk about apnea, bradycardia, acidosis, and pneumothorax decompression. Apnea is common in newborns delivered before 32 weeks of gestation. It's rarely seen in the first 24 hours, but it's defined as a respiratory pause of 20 seconds or longer, and it can lead to hypoxemia and bradycardia. And it often follows hypoxia or hypothermia. Other causes may include maternal or infant opioid exposure, airway or respiratory muscle weakness, septicemia, prolonged or difficult labor and delivery, gastroesophageal reflux, central nervous system abnormalities such as seizures and metabolic disorders. And the pathophysiology of apnea in the newborn depends on the underlying etiology. Newborns need respiratory support to minimize hypoxic brain damage and other organ damage. Assessment includes a careful history to find the etiologic risk factors. Also, performing a physical exam focusing on neurologic signs and signs and symptoms of infection. You should be able to differentiate between primary apnea and secondary apnea. Primary apnea, after a relatively short period of hypoxia, they may have a period of rapid breathing followed by apnea and bradycardia. Drying and stimulation may cause resumption of breathing and pulse rate improvement. Secondary apnea, if hypoxia continues during primary apnea, the newborn will gasp and go into secondary phase. Positive pressure ventilation by bag mask device is then necessary. Bradycardia is most frequently the result of hypoxia. Often responds to effective positive pressure ventilations. That's why we will always begin ventilations and try to have effective ventilations and corrective airway management before we ever consider doing anything, including chest compressions, in the neonatal resuscitation practice. Other causes could include hypovolemia, pneumothorax, head injury, maternal drug use, hypothyroidism, acidosis, prolonged suctioning or intense intubation, and vagal stimulation from an adequately secured ET tube or oral gastric tube. So looking at the neonatal resuscitation algorithm again, remember, if the heart rate's less than 100 beats per minute, we're going to provide positive pressure ventilation and continue to support the airway. Then after we've done that and the heart rate's less than 60 beats per minute, we're going to begin chest compressions. And after we are providing positive pressure ventilations and we're doing chest compressions and the heart rate's still below 60 beats per minute, we're going to administer epinephrine, and then we'll check the pulse after 1 minute. Acidosis. Suspect metabolic acidosis if bradycardia persists after adequate ventilation, chest compressions, and volume expansion. Consider administering a bolus of normal saline to aid in improved perfusion and clearance of acid. The best treatment is to identify and correct the underlying cause of acidosis. A pneumothorax can occur if the infant inhales meconium at birth, the lung is weakened by infection, or positive pressure ventilation is too aggressive. That's why we've got to be very, very careful when we are delivering positive pressure ventilations to neonates. Signs of significant pneumothorax include severe respiratory distress, unresponsive to positive pressure ventilations, unilateral decreased breath sounds, or shifts of heart sounds if a pneumothorax is on the left side. Assessment and management. We're going to do a decompression. Clean the area with alcohol around the second intercostal space mid-clavicular line. Use a 22 gauge butterfly needle attached to extension tubing, a 3-way stopcock, and a 20 milliliter syringe. Palpate the upper edge of the second rib and insert a needle above it. At the same time, a second provider pulls back on the syringe. Slowly advance the needle until air is recovered. If the syringe fills with air, turn the stopcock off to the newborn. Push air out from the syringe, then open the stopcock to the newborn and continue withdrawing air. Remove the needle when there is no more air to be withdrawn. If symptomatic ongoing air leak, insert a 22 gauge angiocatheter in a similar location. Tubing may be taped to the chest and briefly occluded. Place the tubing in a small bottle of sterile water and release the tubing occlusion. This relieves pressure buildup until the patient can be transported. During transport, monitor for reaccumulation of the pneumothorax.